Hi everyone, my name is Cesar Cornejo and I am a first-year medical student at Com Northwest. I am presenting a case on a proximal tibiofibular joint dislocation that was treated surgically with a double-spanning diverging suture technique. These types of injury are very rare and are reported to only make up 1% of all knee injuries. They can be easily mistaken for isolated lateral meniscus tears due to their anatomic proximity and their similarity in symptoms. The patient in this case was a 37-year-old male professional skier who developed lateral knee pain after contusing the lateral aspect of his knee with a metal railing during a ski jump. He presented to the orthopedic clinic with complaints of sharp lateral knee pain that worsened with squatting and descending stairs. A physical exam found mild tenderness at the lateral joint line and exquisite tenderness at the proximal fibular head. He also had a hypermobile proximal tibiofibular joint that subluxated easily in comparison to the uninjured knee. The radiographs were unremarkable, but MRI revealed a small radial tear of the lateral meniscus as well as edema and chondral irregularities over the proximal tibiofibular joint, indicating a dislocation. The patient was treated with a partial lateral meniscectomy and open repair of the PTFJ. A diagram showing the anatomy of the joint and placement of the fixation devices can be seen in Figure 2, and posted pictures with the fixation devices in place can be seen in Figure 3. Some surgery highlights include taking care of to protect the common peroneal nerve during dissection due to its close proximity to the fibular head, and also protecting the infrapatellar and saphenous nerve branches to avoid trapping them in the fixation buttons as they're flipped over the tibial cortex. Also, the suture should be carefully tensioned to eliminate the gross mobility of the joint, but you should also avoid over-tensioning them and limiting the natural motion of the joint. Postoperatively, the patient was on crutches with no weight bearing for a month, and after 5 months of rehab, he was able to return to his pre-injury level of activity with no complaints of instability or pain. Given the rarity of these types of injuries and a lack of control studies, there is no optimal surgical treatment currently known. However, the technique was chosen in this case because the use of two diverging sutures eliminates a rotational axis that is seen when only a single suture or when non-diverging sutures are used. It also seemed advantageous because the patient is very active, and this technique eliminated the need for a second surgery to remove fixation devices, as seen with other procedures such as screw fixation. And that is everything for me. Thank you for listening.